Buenas tardes. Vamos a empezar, vamos muy bien de tiempo y vamos a cumplirlo para que vayamos condiciones de oír al profesor Dayan y tener alguna pregunta posterior que interese. Bueno, en primer lugar, como miembro del comité organizador local, pues quería daros la bienvenida a Granada, también de nuevo. Vais a disfrutar, yo creo, de todo el contenido del programa, pero también de una ciudad que además os ha recibido con un tiempo magnífico, con 24 grados ahora mismo, que es ideal para también pasear y ver la ciudad. Bueno, quiero darle hello, profesor Dayan. Welcome to Granada. Thank you very much. On behalf of the organizing committee and also of the Spanish Diabetes Society for giving this opening conference entitled Prevention of DM1, Clinical Trials Underway. Next, Professor Castaño will try to summarize the brief curriculum vitae of the Professor Dayan. Thank you again.
Thank you.
Welcome.
Ok, buenas tardes a todos. Efectivamente, yo soy Luis Castaño y quiero agradecer a la Sociedad Española de Diabetes y a la organización del Congreso, al comité local, el invitarnos a estar moderando esta fantástica conferencia. Es una oportunidad única y para ello tenemos al profesor Colin Dayan. El profesor Colin Dayan es profesor de la Unidad de Diabetes y Metabolismo de la Universidad de Cardiff. Es endocrinólogo, se formó en Oxford y en el Massachusetts General Hospital de Boston y en Inglaterra, a su vuelta, pues trabaja desde hace años en el mundo de la inmunointervención, de la prevención de la diabetes tipo 1. Él es el responsable de la unidad del trasplante de páncreas en la Universidad de Cardiff, es responsable de la Estrategia Nacional de Prevención de Diabetes y del Consorcio de Inmunointervención en el Reino Unido. En este momento está colaborando y participando y liderando proyectos muy interesantes a nivel del Reino Unido y a nivel europeo de prevención, de screening poblacional. Es un lujo tenerlo aquí. Como muchas personas, es una persona muy ocupada. Tenemos que agradecerle que haya hecho un paréntesis para estar en nuestro Congreso y tener la oportunidad de, en una visita breve, visitar Granada y nuestro Congreso, y bueno, agradecerlo. Thank you, Colin, for being here. Thank you for giving us your present knowledge of this new strategy, era or period of type 1 diabetes that is very promising. Thank you for coming.
Thank you. Thank you. Muchas gracias. Lo siento que no hablo en español. I will be speaking in English. So it's a great pleasure to be here and have the opportunity to talk to you about what I think, of course, is a very exciting area which will change the way we practice looking after our patients with type 1 diabetes. So here are my disclosures. And I've worked with many companies because I want the big companies to come to our disease. Maybe we'll come back to that later on. They treat all the other autoimmune diseases. They don't treat our autoimmune disease, and we want them to do that. So it's a very exciting time, as I think you know, in type 1 diabetes from several different aspects. You'll be very familiar. I see you're hearing more at the Congress about closed-loop therapy and the great advantages that's providing. We're also hearing more about we're now able to make stem cells into beta cells. They still get rejected, but we can make beta cells, which means we can make as many beta cells as we want. We just have to get them protected. So that's another great advance that's coming. Today, I want to talk about the last part, and this is a headline from a couple of years ago. The FDA approves the first drug that can delay onset of type 1 diabetes. November the 17th, 2022, which in my area of work was a critical date, as you'll see a little bit later on in the calendar of changing the way we treat type 1 diabetes. So you could start by the fact of saying, look, we've got all this kit. Do we need any new treatments? Let me give you a couple of slides about why I think we still do. And this is important because I need you to say we need new things. If you all decide we have everything, we'll never change. So I like this slide, and this is the National Pediatric Diabetes Audit of the UK, and it's the HbA1cs here. Oops, let's go back. I don't know if I have a pointer. Maybe we can. Yeah, we go. And this is years of diabetes, and this is different ages. So in the first year, 1 year, 2 years, et cetera, et cetera. So you can see here that everybody does well in the first year. And then they get worse. Is it because they forget? They don't know what to do? Why would it get worse? And of course, it particularly gets worse for teenagers, these 15 to 19-year-olds. You know why it gets worse, because it's too hard, and it's difficult to keep going with it every day and changing all the things. So what this is telling us is that at the beginning, everyone can do it, and then they can't. And what is happening is they're losing their own beta cell function, their endogenous secretion of insulin. When you have it, everyone can do it. When you don't have it, many people can't. Which people can't? So this is the same data from the UK. So it's all the children in the UK, 29,000 children. But now it's split by deprivation. So the red line is the worst socioeconomic class, or most deprived, and the blue line, the black line is the best. Now, over the last 10 years, the pediatricians have done very well. The HbA1c is falling, but it's falling least in the most deprived areas. So there are people being left behind by all of these things. And also, to talk about age, this is something we published recently. I suspect it's the same in your country. If you look at HbA1c here, and you look at age along the bottom, it peaks at around the age of 19, but really it's going up from about the age of 13 or 14, right until the age of 27 or 28. During this period of time, the young people are distracted, they've got other things on their mind. Particularly, it's more striking in the females, and they get admitted, this is admissions with DKA, more frequently in females. And you know, some of this is to do with weight loss and manipulation of insulin. It happens. But this is bad because you want good control at the beginning because it affects long-term complications 30 years later. It doesn't matter having good control when you're my age, but it matters when you're 15, 5, 10, 20. These are the important times. So this is not good. We want to flatten this out so we get good control for the first 10 and 20 years. And this, which is, again, the same audit, but it's looking at the need for psychological support. You'll be aware that a lot of families need psychological support in the first year, but it keeps on going. And 15 years later, another 40% of the families still need psychological support. It's a huge burden, isn't it? Every day, it's a struggle, every day. Although they're doing better, it's by working really, really hard. And you're working very hard. The amount of time you spend on insulin and administering insulin and changing insulin, what if we didn't need it? What would you do with yourself every day? It would make a huge difference to your psychological burden as well. And just finally to say, so again, this is the same audit, but it's looking at the percentage of, this is the mean HbA1c, the percentage that are under 58. So the people in blue, they will have a very low risk of complications. Orange, well, this is between about 58 and 80 in millimoles per mole. But there are still children here who are running 14% of them with high levels, more than 10% in the old money, more than 80% now. These are the people who will get retinopathy in their 20s, and they will need many of them renal replacement in their 30s and 40s, and will cost a lot. So we have to find a way of helping these people not just these people over here. So the summary of this is to say, the people who most benefit by preserving C-peptide, if you preserve, you're familiar with C-peptide, that's the measure of your own endogenous insulin. If you have more endogenous insulin, it will help particularly those people who are least engaged with their own self-care, teenagers, young adult, disadvantaged families. I haven't talked about mental health problems, but you know mental health problems. I always say to my students, anorexia nervosa and type 1, they don't go well together. Drug abuse and type 1 diabetes, they don't go well together, and you end up with a very bad outcome. And we can't help those people with insulin. And people, of course, early in the disease course. Okay, so that's the background. That's why I think we need more. We've got a lot, but we need to get better. So in the UK, we have a research consortium, as Luis mentioned, and we have a new strapline. Oops. We have it moving towards insulin-free T1D. And I want you to keep that idea in mind. You can have type 1 diabetes and not need insulin. This is very disturbing because it used to be called insulin-dependent diabetes. And then if you don't need insulin, is that not the same condition? Well, you'll see. So what we have here is to remind you, this is an autoimmune condition. This is not a metabolic disease. This is an immune disease. It just happens to come to us because in the end stages, it's metabolic. But it starts with, here's an intact islet. The brown is insulin. The red is glucagon. Then you get insulitis. And then you get an islet here with no insulin and only glucagon left. And that is the process. So if it's not a metabolic disease, it's an autoimmune disease, which targets the insulin-making beta cells, well, let's treat the autoimmunity. So if we can slow or halt the autoimmune process, we can delay or avoid the need for insulin therapy. So the idea is very straightforward. We just need to do it, right? So what kind of things can immunotherapy do? I'm just showing you this. This is a curve of the decline of C-peptide. In fact, it's the number of people with a low level of C-peptide, less than 0.2 nanomoles per liter. Here's little children under the age of 12. They progress much more rapidly after the diagnosis, slower in 12 to 17, and slowest in the adults. So one thing that immunotherapy could do is to slow it. Even if it doesn't stop it altogether, it can convert this into this. And then you have many more years when you have enough insulin. Or looked at another way, this is the graph that I showed you before. Why can't we take these people back to there? Or keep them there? Because then everybody can get a better HbA1c. So these are the kind of things we're trying to do in preserving beta cell function. So I like to say preserving as much endogenous beta cell function as possible for as long as possible has the potential to improve outcomes. So if you do it for 5 years, then people have a better HbA1c for 5 years. In the DCCT trial, it was only 7 or 8 years that they had a better HbA1c, and they had advantages for 30 years after that. So the longer the better, the more the better. And of course, especially for those least engaged with their therapy. Okay, we have a supermarket. I don't know if you have Tesco, but their strap line is every little helps, every little bit of beta cell function helps. And there used to be another advert for a Heineken beer, which said, Heineken refreshes the parts what other beers can't reach. So the idea is it'll reach into patients that you can't reach with insulin, you can reach them with beta cell preservation. Okay. Right, so now I need to just remind you, if you're not familiar with it, or introduce you to the stages of type 1 diabetes. I'm sorry to say that when a patient comes to the emergency room losing weight and very thirsty for the last 6 weeks, and they say, I've been sick for 6 weeks, that's not true. They've been sick for many years, but they don't know it. And we call that now stage 3 type 1 diabetes. That's here, when they're symptomatic, and they have glucose levels that are diagnostic of diabetes. But by that time, they've lost about 80% of their beta cell function. A lot was going on before that. So now we're able to test for the early stages of autoimmunity. We define 2 earlier stages. We define a first stage when you have 2 or more autoantibodies, but you have normal blood glucose, because you've got a lot of reserve in your beta cells, especially if you're slim. So you can lose half of your beta cells, and you'll still have normal glucose, but you've lost a lot. And then later, as you lose more, maybe 50 to 80%, we don't know exactly, you become dysglycemic. Yes, you can have impaired glucose tolerance in type 1 diabetes. We tend to think of it as something for type 2, but you can have it in type 1. So it means you don't technically have diabetes. You're not at risk of microvascular complications, but you've got a 2-hour glucose that is between 8 and 11. It is raised. It is dysglycemic. So it's not impacting you for microvascular risk, but it's telling you that clinical diabetes and the need for insulin is very close now. So a bit of the evidence behind that, to remind you. So these are studies that have been done over 20 years or more in different parts of the world, looking at different autoantibodies. So these are islet autoantibodies, anti-GAD, anti-IO2, anti-ZNT8. And those are the 3 most common ones. Anti-insulin can also be measured. And anti-tetraspanin 8 is going to come as well. So if you have only one of these antibodies, you progress very slowly. So after 20 years, only about 20% have developed clinical diabetes where they need insulin. But if you have 2 or 3, so 2 different ones or 3 different ones, then you're going to get it. It's going to happen. It's just a matter of time. And by about 15 to 20 years, around 80% of people have already need insulin at that point in time. So that's why we define stage 1 as having 2 or more, not 1, but 2 or more different autoantibodies. Now then, when you get to the stage of dysglycemia, I said it's very close. And this is the evidence. So if you take people who are dysglycemic with 2 or more antibodies, they, if they've got normal glucose tolerance, they're going slowly. So after about 7 years, only half of them have developed diabetes. But if you have dysglycemia, in 5 years, pretty much all of them will have diabetes, or 80% of them will develop diabetes. So you know it's very close. It's going to happen quite quickly. I would ask you to remember this number, 80% in 5 years. We'll come back to that in a moment. So it's official. The American Diabetes Association says there's 3 stages, so we have to believe it. There are 3 stages of type 1, and we tend to only think about stage 3, but we need to think about stage 2 and stage 1. So that's the stages of diabetes, and now the immune system. Now I know I'm an endocrinologist too. Most people hate the immune system. We don't understand it. It's very complicated. It's something other people do, other specialties. I'll give them a phone call. They'll sort it out. But we have to just introduce you a little bit to the immune system. It's quite complicated, of course. But each of these gray boxes is not part of the immune system. It's a drug. It's a monoclonal. It's a biologic that affects very different parts of the immune system. So we now have very selective tools for hitting different parts of the immune system. That's very important because we can do it much more safely than we could 20 years ago. So I'd like to emphasize that when I'm going to talk about immune therapies, I don't mean this. I don't mean drugs for organ transplantation. I don't mean cyclosporin. I don't mean tacrolimus. I don't mean those kind of drugs. I don't mean long-term immunosuppressive therapy, which carry a high risk of side effects. What I do mean is this: selective immunosuppression, which some people call them biologics, and almost every other specialty except ours uses it. Respiratory, GI, dermatology, rheumatology, all of them use it every day and with very good results. It's about time we begin to think about this a little bit because they have a low risk of side effects. Now, we don't have these yet, but a lot of people are trying to develop them. I like to call this an unvaccine. So if you gave proinsulin in such a way that it switches off the immune response to the pancreas, you don't affect the whole immune response, just the one that you want to get at. So it's antigen specific. A lot of people working on this for all autoimmune diseases. We don't have it yet. It may come in the next 5 to 10 years. It's a bit like cancer vaccines. This will be our vaccine, but not yet. However, we do have lots of things. Now, I like to hate psoriasis, not because I have psoriasis or any other reason, but it's because they have 11 licensed therapies when we have 0 for new onset type 1 diabetes, 0 in Europe anyway. Why do they have all these? Which is the more dangerous disease, psoriasis or type 1 diabetes? Is it because this is a nastier disease? No, it's because they've engaged with this disease and they realize the benefits that they're getting out of it. In fact, we now realize that many of these drugs, for example, etanercept, ustekinumab, I'll come back to, because do actually work almost certainly for type 1 diabetes as well. If you go into rheumatoid arthritis, the number is enormous now of different drugs. It's not just methotrexate, like maybe you learned about in medical school. Look at the number of different drugs they have for RA. And that means they can zig and zag, they can switch people between therapies, they can use 2 therapies at the same time, and they can make sure that people continue not to develop joint destruction. So now it's quite rare to see destructive arthritis in RA because they prevent it. So do we have any drugs? And the answer is yes, we do, and the list keeps getting longer here. So I've put 9 drugs down here. There's another one, actually, IL-21, that I haven't added that needs a combination. So we have drugs, and you're going to say to me, why aren't we using them? Well, we're starting. And we have some other drugs that are going to report soon. Clinical trials are coming along. So most of these drugs have been trialed at stage 3. You're familiar with the stages now, so you know what stage 3 is. That's when they've just been diagnosed. New onset. We can't leave it too long because they're losing beta cells very quickly. And within a year, they'll have lost a lot. Within 5 years, they've lost almost everything. So we need to get in there early. The one thing we cannot do at the moment is regenerate beta cells. We can't put them back, so we have to start early. You could say it's a bit like multiple sclerosis. We can't put the brain back. We have to prevent it being damaged in the first place. So this is where most of the trials have been done. And I'll show you just a few examples. Here's one from 2020. This is golimumab, which is, you may not be familiar with it, but it's an anti-TNF. And in fact, it's been around for about 15 years. It's been quite widely used for juvenile idiopathic arthritis and arthritis. So it's been used down to the age of 2 years old is licensed for this drug. And they tried it in new onset type 1, and this is the kind of data we always see. So up this side is C-peptide, so this is your endogenous beta cell function. These are stage 3, these are people treated with insulin. So we can't measure insulin because we'll pick up the insulin they're injecting. We have to measure C-peptide. So that's what we do, and this is changed from baseline. Here is the placebo. Over 1 year, I said they're losing beta cells quickly, and they are. And this was a subcutaneous injection every 2 weeks. Not 5 injections a day adjusted for meals and exercise. The same dose every 2 weeks, 1 injection, subcut. That was all the therapy was. And here's the degree of preservation that they see. And again, the safety was very good with golimumab. Here's the most recent one in December 2023. This is a drug called baricitinib. So rheumatoid arthritis has moved on from monoclonal antibodies. They're now using these are called JAK kinase inhibitors, and they're tablets that, not injections, they block the action of the cytokines. And so this was used in type 1, and you see perhaps a very similar result here. Again, C-peptide up here. And here is baricitinib. There's almost no loss of beta cell function over 48 weeks, whereas the placebo continued to decline. So we definitely can do this. We can definitely slow this disease. So everybody worries about safety. Now, the best way I think of looking at safety is like this. So here is the risk of being admitted for a serious infection. So septicemia, that's serious, right? That's a bad thing. In the general population, it's about 0.6% per year. If you have a kidney transplant, it's about 10 times higher than that, about 6% per year. Don't forget that badly controlled diabetes increases your risk of sepsis. You know that, don't you? So even then, the risk is already increased to around this level, a 7-fold increase. Having type 1 diabetes at all increases your risk of serious infections by about 3-fold. So where do the drugs sit here? So we only have this data on drugs that have been around for many years. So for example, for anti-TNF, we have this data. For another drug, ustekinumab, we have this data. This is where they sit. So for anti-TNF, it's much less than having diabetes itself, the risk of sepsis, maybe about 50% increase, 1.5-fold. With ustekinumab, which we've just been working on, you almost can't detect it at all, that there's any increased risk of sepsis. And this is 100,000 patients worth of data over 9 or 10 years of follow-up. So this is not a small data set. So that's why I want to re-emphasize selective immunosuppression is very low risk, and it's actually less risk than not treating your diabetes properly. Okay, but you're going to tell me I need to be very safe now because I want to move up. And my title is prevention, so I've got to do some prevention, and I can only prevent if I get in there before the disease happens. So now I'm talking about here, stage 2, can we intervene here? Well, there's another year, and this is a paper I think many of you will be familiar with, June the 19th, 2019. And this was Kevin Herald's study. And so he was doing the first study. It wasn't actually the first study, but there was the first immunotherapy study in stage 2. So remember stage 2, that means they don't have the disease, but they've got dysglycemia. And remember the percentage that they're going to need insulin in 5 years, it's going to be 80%. They're going very quickly. So that's good for a clinical trial because you need people to progress. So the results are probably quite well known to you now, and this is actually extended follow-up of the study. So the treatment was a monoclonal antibody teplizumab given over 14 days once. 2 weeks of therapy, no more treatment. So it was given up here, and this is 6 years of follow-up, no more treatment. There's nothing the patients could do to get it out. It was in them, right? The treatment is done. They can't not comply with this therapy. It has happened. And what they saw on average, yes, it didn't stop the disease altogether, but there was on average about a 32.5-month delay in the people treated here. This is the placebo, and I said I would come back to it. The placebo did exactly what we predicted, which is that after 5 years, 80% of them had developed type 1 diabetes and needed insulin at that point in time, whereas it was only around 50% with the teplizumab. It's not perfect, but it's a major advance, and definitely we're changing the course of the river here. How does teplizumab work? Well, this is a cartoon to explain it. I'm not sure we all fully understand it, actually. But what it does, it's an anti-CD3. It binds to all the T cells, and the T cells are causing the damage. So in this cartoon, these are beta cells here, and the red is T cells that are attacking the beta cells and killing them. And what the antibody does is it doesn't get rid of the T cells altogether, it kind of pushes them over the edge, so they become what's called exhausted. They get into a phase where they're still there, but they can't function anymore. So that's the idea, that it pushes them into an exhausted state, and that changes the balance of immune regulation to activation, so the immune system can rebalance itself, at least for several years, until these cells begin to reemerge again. In terms of side effects, I thought I'd just show you this, actually. We took part in one of the studies with teplizumab, my colleague in Sheffield. In terms of side effects during the treatment, you do get a flu-like reaction, like it's a small cytokine release, not a massive cytokine release. And a lot of biologics do this, where you get a peeling rash like this, but only during the time of therapy. After the 2 weeks or 3 weeks of therapy, it never comes back. It's never a problem. And this is what happens to the T cells with teplizumab. So these are the days of treatment. The T cell level drops, and then it comes back. Actually, it's not easy to explain why it drops. It seems that they go out of the circulation, but they don't die, because then they seem to come back again, because they reemerge here about 2 weeks later. If you destroy all T cells, it takes months for them to come back. So this can't be killing them all. The important point is that by about 3 weeks, the T cells are pretty much back to normal. And that means that the infection risk has gone. There is an infection risk over this period of time, but for the rest of the time, those other 2.5, 3 years, there, as far as we can make out, there is no increased risk of opportunistic infections, herpes, Epstein-Barr virus, any of those things. It'll only happen during that short period of time. And even then, the risk is low. So the FDA considered this was a breakthrough. To see that data in 2019, that you could delay diabetes by 2.5 years, they took it to a meeting in which they have important people discuss this. And many of you will recognize, for example, David Nathan here, who was the father of the Diabetes Control and Complications trial. And they said to them, can you say this? Does the information about this drug show that the benefits of teplizumab outweigh the risks in support of approval to delay clinical onset? To me, this was a critical moment of saying, is immunotherapy better than just waiting to do insulin? And in the end, the vote was 10-7 at that point. Actually, David Nathan voted no. But gradually, the attitudes are changing. For the first time, people are beginning to think, on balance, this is a better thing to do, rather than just wait and give them insulin. And it was licensed I mentioned before, November the 17th, 2022, very exciting moment. It's now called Tzield, and it's licensed in the USA. It's got a proper label, blah, blah, blah. It's available. Quite expensive. Now, some people say to me, okay, Colin, 2.5 years, 3 years, just do it, right? Just wait. Just, come on, let's have the insulin. Let's get on with it for life. What are the advantages of a delay of 2.5 years on its own? Well, I don't need to remind you, if you're not on insulin, you can't have hypoglycemia, right? Hypoglycemia is not caused by diabetes, it's caused by the treatment for diabetes. Because it's got such a narrow therapeutic index, insulin, we see a lot of hypoglycemics. We live with hypoglycemia all the time. You cannot get hypoglycemia during this period of time. You can fly a plane, you can do whatever you like. There is no risk in this situation. And you don't need any lifestyle limitation. Doesn't matter what you eat, doesn't matter what exercise, you can do your marathon, doesn't matter. You don't even have to monitor during that period of time. No need for monitoring, all those texts, worrying about it. Nothing is going to happen. And during this time, it's what I call money in the bank. There is no risk. You're not accruing a risk of metabolic complications. You are not in the glycemic range, which puts you at risk for glycemic complications. So it's like you gain 3 years advantage. It's like DCCT, but even better. You get 3 years of DCCT for doing nothing, without much of an effort in doing that. So it's delaying your long-term complications. And I would say improves your quality of life. Okay. So there is a catch here. We can't find the patients. We want to prevent it, but they're not coming to us saying, can I have teplizumab, please? Because they don't know. They have no symptoms at this point in time. So we're going to have to screen to be able to find them. And screening is not that easy. But there are advantages of screening in itself. This slide shows a lady from my area in Wales whose son died at diagnosis. And it happens in the UK about once a year. It probably happens in Spain about once a year. Undiagnosed ketoacidosis, severe, and they leave it too late because no one realizes they have type 1 diabetes, and sometimes it is too late. Normally, of course, we can treat them. They go to intensive care, but it's a terrible shock for the families in that situation. We've had lots of campaigns of telling people about the symptoms of type 1 diabetes. It never works. People never remember because 90% of type 1 diabetes doesn't come from families. It's out of the blue. They don't know anybody. They don't know what this disease is. The GP says, oh, they're just losing weight because they're a teenager, or this or that, or they're just not feeling very well, or whatever, and then they get very sick, and people go, oh, I understand what this is now. This is looking at DKA rates across different parts of the UK. I'm guessing it's probably the same in Spain. It's around 20%. It got much worse. During COVID, it was around 40% DKA rates, people presenting the first time in life-threatening diabetic ketoacidosis. And these rates have not changed in 20 years, or in 30 years, actually, because we can't change them, right? It's not you, because you don't see it until it actually hits your door, and it's too late. But screening does change that. So let me just, oops, sorry, what have I done here? I might have made a mistake here, because I might have clicked on the video, and I don't want to do this. There we go. So if you screen, if you test for the antibodies, once you know you're positive, we have the expression in English, a watched pot doesn't boil. So when you know something's going to happen, it won't happen because you're watching it all the time. And that's exactly what you see. For example, here in the large screening studies, Frieda, for example, in Germany, the expected decay rate was 32%, it was 3% in the screen subjects. So it's a massive reduction in these admissions to hospital. You don't need to admit them to hospital because you see it coming. You can prepare them for insulin as an outpatient. You can have a conversation. You don't have to rush to the emergency room. It's a much more gentle process, what we call a soft landing. In fact, you don't even need to admit them to hospital here. Here's hospitalization rates dropped in the DAISY study from 44% to 3%. Don't admit patients. In fact, make sure they never get anywhere near the hospital. They don't need to come into hospital. It's an unpleasant experience. That's their first experience of diabetes is hospital, and we don't want that to be the case. So that's in screening also the big issue is familial versus universal screening. So people in families have a 10-fold higher risk. It's about 1 in 30 if one first-degree relative, a brother or sister or a mother, has type 1 diabetes. It's about a 1 in 30 risk for the first-degree relatives to develop type 1 diabetes. In the general population, it's 1 in 300. So if you want to find people, it's easiest to take the relatives. And I was talking earlier on to Luis. People say, oh, universal screening, oh, we can't do this, it's going to be too hard. And I say, well, why don't you look at your waiting room in your clinic, right? Look outside, there's the brother, there's the mother, there's the, the sister. There, you can check those people. It won't take you much effort. Well, it is a bit of an effort, but it's a very simple blood test. It can actually be done on a finger prick. And they're waiting in the waiting room. Now, they tend to not want to be screened if there isn't a treatment, so that you get a bit of a catch-22. When there's a treatment, I'll get screened. If I'm not going to get screened until there's a treatment, etc. But at least 10% of the population is within our grasp as endocrinologists. But then, to actually prevent diabetes altogether, we do need to screen the whole population. And that will be a huge effort, and that will be primary care. That can't be diabetes because we don't see it, all the people, right? We're going to have to screen every child in the population. So to actually prevent DKA across the population, actually families don't get DKA very much because the second child, they see it coming. But it's the first one where they do get high rates of DKA. So really to prevent DKA, you do need familial screening. And screening is hard work. This is the FRIDA study in Bavaria that you may be familiar with. And for example, they screened 90,000 children aged 2 to 5 to identify 310 that were multiple antibody positive. But it works. Almost all the new cases here, you can see, were coming from these 310, not from the 89,000 that were negative. There are a few cases, about 10% are antibody negative, so it can happen, but the vast majority are coming from here. Just out of interest, it's useful for you to see that if you do screen and you get multiple antibody positive, about 80% of them are in stage 1. Remember that? That means that they don't have dysglycemia. They're in an earlier stage. It means they're not eligible currently for teplizumab. So they would have to wait and be observed to get to the point where they become dysglycemic. You would have to monitor them to do that. About 10% are in stage 2. And what I always find funny is that about 10% already have diabetes. They just didn't know they had it. And they were not symptomatic at that point in time, but they're picked up at this point. This is always very interesting to watch how diabetologists react to this. Having somebody with a 2-hour blood glucose of 12.5, double positive antibodies, an HbA1c of 43 or something, what do you do? Because we're trained to give insulin today. That's what we get. When you diagnose type 1 diabetes, they must have insulin today, the latest tomorrow. These people don't need it. They don't need it for months, actually. And often they can control it with carbohydrate restriction if they want to, with physical exercise, with other treatments. And it's very interesting to watch how that happens. It's a much more gentle process than we're used to. There are other approaches to screening which I won't be going into today, but you can do genetic risk. So we've got quite a good genetic risk score. It looks at 70 SNPs across the genome. And essentially, it converts the general population into family members. So it identifies people with a 10% risk. So that's a bit more, 3 to 10% risk. So it converts you into having the background risk, which is about 0.3%, to having a 3 to 10% risk. But if you do genetic screening, which you can do at birth, of course, the problem there is you're upsetting 90% of the population, because 90% of the people with a high genetic risk will never develop type 1 diabetes. That contrasts to if you have 2 or more antibodies, 90% will develop diabetes, so you can say they have the disease. So it's a little bit more tricky to manage. I don't think we're ready in the UK for genetic screening because people have to get used to the idea of risk and living with the fact that they've got risk. To be honest, it's the same as living with a sister who's got type 1 diabetes. You know her at risk. You might want to watch out for it. Something we can discuss if there's questions at the end. But at the moment, screening is not using genetics. It's using autoantibodies' actual change in the serotype. And there's much debate about what age to screen. If you screen at 6 months of age, no one has the antibodies yet. If you screen at 12 years of age, 50% of them have already developed diabetes. You're too late to intervene. So there is actually a peak of seroconversion that happens around the age of 2. So a lot of people say you should screen around the age of 3.5, which for us in the UK is quite useful. That's school entry. So we have a preschool vaccination, and that might be quite a good time for general practitioners to do the screening. Other people are saying you should do a later screening because that will only pick up about 70%. you may need to rescreen around the age of 8 or 9. There's much debate about whether you need to do it twice or not. And finally, there is the anxiety. So a lot of people say, and the families say, don't tell me, I don't want to know that my child's going to develop diabetes. I've got it, I know what it is. I don't want to know this, and I have to watch them for 5 years before they develop diabetes. Well, I think it's important to remember and talk to your patients about what it's like to be diagnosed suddenly, diagnosed the way it is now. It's incredibly stressful. You go from thinking you had a healthy child to knowing they're going to be on insulin for the rest of their life. And you do that within about 1 week. And then you have to learn everything about diabetes, everything about carbohydrates, everything about monitoring, all in that short space of time while your child is in intensive care. That's a very painful process. Whereas here, obviously, when you tell people they're at risk, it is a big shock, but they've got time. And they've got time to adjust to it, to go onto the internet, to talk to the families. They've got time to talk to other people. They've got time to read about insulin, have a group discussion. And so what you see, this is data from the Frida study also, looking at anxiety levels. And what you see here is the anxiety level here, when they're first diagnosed, is raised compared to controls here. But within about 6 months, it actually gets around to the background level. And if you compare it here to the level of anxiety when you're diagnosed the way we do it now in the community, it's about half the level of anxiety. I can see someone smiling in the front row, and they've noticed that only mothers care and fathers don't care. So the level of stress in fathers seems to be very low, whatever happens, even if, well, they're still worried if they're diagnosed in the community. I'm not going to go into whether mothers worry more than fathers. But the point I want to make is, of course there's a worry, but you can deal with it over time, and you have an opportunity to deal with it. And overall, the evidence suggests that the stress level is less. And these, remember, are people that are going to get diabetes anyway. It's going to happen. It's giving them the information up front. Okay. So actually, my title was Clinical Trials Underway. So there are relatively few trials. I mentioned, obviously, about teplizumab and how that's licensed. There are other drugs that are being used in stage 1 and 2. So actually, we currently have a trial starting in the USA called TN28, or Stop T1D, which is looking at anti-thymocyte globulin, and that's a 2-day infusion in stage 2. But there was also a study that you might have seen with a drug called abatacept, which has been around for 15 years or so. It's used in rheumatoid arthritis. It stops T-cell activation. It's called CTLA-4 Ig. And, oops, here it is. Sorry, I put it in the wrong order. This is the abatacept study. This study makes me cry when I look at it, because they didn't do it for long enough, and they didn't do enough people. But clearly something was happening. So here you can see this is the first study, actually, with an immune therapy agent in stage 1. Right? So this is harder. This is where they're progressing much more slowly. So along the bottom, you can see they're followed up for 7 years here. So the first endpoint was progression from stage 1 to stage 2. And then over here, this is progression to stage 3. In other words, they need insulin. Very few of them have progressed to stage 3 even after 5 years. So it was very difficult to see the separation between the groups. If you look at this and I look at this, you think the red line is lower than the blue line. In other words, there was some prevention by abatacept, but they only treated for 1 year. And this is a drug that in rheumatoid arthritis is continually done. It's now given subcutaneously every 2 to 4 weeks. They gave it just intravenously for 1 year, and then they stopped. So, and the power of the study was smaller than it should have been, around 200 individuals here. So I think this was working, but they didn't give it enough time. So it can work in stage 1. It's harder to do. So at the moment, we don't have a therapy that has proven efficacy in stage 1. We want to treat stage 1 because that's when you've got lots of beta cells. You want to keep as many as you can, and then life is going to be going on for you as long as you can. And if you do it in stage 1 and you start to lose beta cells, you can have another treatment for stage 2. So you've got time, whereas you don't have it in stage 2. So go back a little bit. I did summarize over here. There are treatments that have not worked in stage 1 or in early phase and in diabetes generally. So we've still got ongoing therapies with GAD65. This is an antigen-specific therapy. I think many of you may be aware of oral insulin and nicotinamide and these other studies that have used, these were in the prevention arena as well, and were not effective. So teplizumab there are other drugs. I've shown you the 9 other drugs that are already working at stage 3. We need to move them upstream a little bit. So there are lots of places we can intervene. I talked about stage 3. Actually, intervening at stage 3 is less attractive now because closed-loop therapy is very good at stage 3. But what closed-loop therapy cannot do is have you no insulin, is for you to be insulin-free. They will never be able to do that. That's what therapy at stage 2 can do. That's what therapy at stage 1 can do. And people are even looking here. You can call this stage 0. And one of the factors that we know precipitates type 1 diabetes is enterovirus infection. So we're beginning to think about vaccinating children with enterovirus vaccines to see if we can reduce the number that actually even seroconvert at all. I told you that if you've got a genetic risk, you still only have a 10% risk of progressing. If you have an identical twin, it's still only 50%. So there definitely is an environmental event that is required for this to happen. And of course, over in stage 4 over here, this is not my subject, but this of course is beta cell replacement therapy. However, I wanted to mention it because I'm waiting for the beta cell replacement people to make autologous beta cells. If they make it from my stem cells, and they make beta cells from my stem cells, then if I have type 1 diabetes, I will still reject them, but because of autoimmunity, not because of allograft rejection. And autoimmunity is what I do every day. All the drugs I've just shown you are treatments for autoimmunity. They're not strong enough to protect a transplant, an allograft, that's not mismatch. But if they could make me autologous beta cells, give them to me, I'll put them into the patient, and they will look exactly like my stage 2 patients, right? And I can now treat them with immune therapies. Okay. So a very last point I want to make is that if you're thinking about trials in early stage, there is a problem in measuring C-peptide. When I showed you trials in early stage, I didn't show you any C-peptide data. I show you C-peptide in stage 3. But in stage 2, in the early phase, it's a bit strange. Look at this. This is years before diagnosis. This is Carmela Evans-Molina data. Here's fasting C-peptide. It's going up. Here's area under the curve C-peptide in an oral glucose tolerance test. It's going up. But it should be going down because we're losing beta cells. The reason it's going up is that the glucose is going up, the fasting glucose and the 2-hour glucose. And that's because as the beta cells fail, the glucose goes up, and that gives you extra drive to your beta cells. So although the level looks high, it's actually not really high. It's just being driven much harder. The stimulus is much greater. And when we give them sugar, their sugar goes higher, and it drives their beta cells more. So it paradoxically looks like this is happening. So you can't use C-peptide on its own as an outcome marker. And a lot of people are looking at that. And this is to say that we probably need to use things like the first phase insulin release here. This is in a healthy beta cells, this is insulin release here. As you progress through stage 1 to stage 3, one of the first things you lose is the first phase. But the area under the curve looks the same because you get a delayed secretion of insulin. So the total amount of insulin over 2 hours is the same, but actually it's not happening early on. So that's one thing you can measure is first phase insulin release. That's very sensitive. And there are other composite markers such as index 60 here, which is relates the glucose as a formula on the bottom, glucose to the C-peptide together, modeled together over the first hour. And that gives you a much better relationship here to progression to diabetes than C-peptide does on its own. Okay, so that's all I wanted to say as the conclusions. We have the tools to identify and intervene prior to insulin independence in T1D. And this confers health and quality of life benefits beyond advanced insulin therapy can provide. Unfortunately, population screening will ultimately be required and is a major effort, but it will reduce acute illness at presentation. And with the advent of the first licensed therapy, it's now time to start screening once these therapies come in, because now there is something to screen for. So I like to say now, it's not if we should do immunotherapy, it's when. When are we going to start doing this? Because it is going to happen and it is going to work. So if you want to look at it this way, the discovery of insulin in 1921 was fantastic. It converted a fatal disease into a chronic disease. But why don't we just push it out later and later until in 2041 our medical students go, never seen a child with type 1.
Thank you, Profesor Dayan. Generalmente en las conferencias magistrales no tenemos preguntas, pero como tenemos 5 minutos, si alguien quiere hacer alguna pregunta, no sé si hay micrófonos en la sala. Sí. Si alguien quiere, sí.
Yeah. Thank you, Colin, for this great talk. I wonder how the FDA approved the indication just having the data of just one phase 3 trial. If you dig into the data, most of the participants were not parents. They were just younger people, and they seem that they extrapolate the results to the whole stage 2 population. What is your guess about what the EMA and your agency will do at the UK?
Yeah. So it's a really good point. I mean, the point you're making is normally with drugs, you need 2 phase 3 studies, much larger studies to approve a drug. But this study took 10 years to do. And the argument they put is that they had quite a bit of safety data because teplizumab is an antique drug. It's been around for 25 years. We know a lot about it in terms of safety. And if the FDA had said, no, you need to do it all over again, then there'll be another 10 years before there was any benefit to patients. So that's the argument that the FDA accepted, that the benefit risk, which is what they have to decide, was still in favor of doing this. The EMA and the MHRA do listen to the FDA. It's not very usual that they don't follow what the FDA says. They put other constraints. And a lot of it is money, because the FDA licenses without any cost issues. I mean, if you don't know, in America, it costs $250,000 for this 14-day trial, right? So that's not going to happen in the UK, I can definitely tell you that. As somebody said to me, drugs don't price themselves. They don't invent their own price. The company invents the price. And the price depends on what you're willing to pay, and also on the number of people that think they're going to treat. So I think that the price will be important in terms of the healthcare systems, but I think it will be surprising if they decide that the benefit and risk ratio is wrong. And what the company are now doing, so this was done by the company Provention Bio, it was a small company, and they were bought at the end of 2022 by Sanofi, very big company, who are investing this in a lot. And they're doing other studies. They're doing post-marketing studies. They're following these patients up. They're now doing a study down to the age of 2 years old, so they can get it younger. So there will be more data coming along. It's not unusual that particularly cancer drugs are licensed with a small study, and then they have to come back to the regulatory authorities 3 or 5 years later and say, is it still working? Do you still see the effect if you collect more data? So I'm with you. I was very surprised, but very pleased, because I think it's hard to go back from this point now, and I think it will influence the other regulatory authorities, but only time will tell. And the one last point I would make is, I think I said at the beginning that the biggest problem for immunotherapy is diabetologists not liking immunotherapy and being scared of it. And so if the regulatory authorities include diabetologists on their panel and they go, do you want to do this? If they include some of you, they'll say, no, we don't like this kind of drug. Give us insulin, we're fine. We need the community to say, that's why I tried to give this talk today, to say, no, we want this to come. Every other disease has it. We want it to come. We want it to come safely. We have the advantage that a lot of these drugs have been tried in other conditions. They've done all the hard work. So we need to help the regulatory authorities say the benefits, because we understand the benefits and they understand the risks. We understand the benefits and what this can bring.
Al fondo.
Thanks for your comprehensive and emotional talk. I would like to stick to your last point. Don't ask if, but just ask when. So we are struggling now how to do the screening. So there are some different. You have explained very well all the difficulties for screening, but we have in our offices some slowly evolution patients that are in very long honeymoon periods. Could we think of doing something with these people? I mean, could be an example of a target to act in this very specific diabetic persons.
I'm interested to know what you're thinking here. So I thought you were going to say, how do we get started? So that was my argument, that let's start with the relatives, because that's quite easy, and we can do it. As diabetologists, we can do it. I think you're asking other things. So I bet everybody in this room has seen early type 1 diabetes. And it's happening because people do HbA1cs, probably like you in the UK, everybody gets their HbA1c done for type 2, where they've got type 2. And then they say, oh, your HbA1c, it's like 5.9%, but you've got a BMI of 21. What could that be? Oh, we'll do your autoantibodies. Oh, you have early type 1. Oh, God, what am I going to do about this? What will happen next? Do you have patients like that? I'm sure you do, or you get asked about these. And then you think, oh, I don't know what to do here. The patients usually do things themselves, which have never been tested. They increase their physical exercise, they restrict their carbohydrate intake, and that probably does delay, but we proposed a lifestyle intervention. Lifestyle intervention for type 1 diabetes, what's this idea? But it probably would work for a period of time. The thing is, we don't measure C-peptides in clinical practice, at least I don't do it on a regular basis. There are certain levels. If you have a C-peptide level that is over 600 picomoles per liter, your risk of DKA is very low. So you can treat these people in other ways. There's a trial that used SGLT2 inhibitors in this population because it will lower their glucose. And this is now the population who are really what I call stage 3A. They have just raised glucoses, but they have quite a lot of beta cell function, a very low risk of ketoacidosis, and you want to keep them there. Other possibilities you may have seen, there's been 2 studies, I haven't talked about it. I think someone's going to talk later in the conference about immunotherapies, but one is the drug verapamil, which costs nothing, $1 a day, whatever it costs. It's been around for 50 years, and 2 trials have already said that slows beta cell preservation. We have just finished recruiting. We will finish next week. The biggest trial of verapamil in new onset type 1 diabetes. If a 3rd trial shows this, what are we going to do? And I say that because I don't think any company is going to license verapamil for type 1 diabetes, because they're not going to make any profit out of it, right? They're not going to do 2 phase 3 studies because that will cost a lot of money. So we'll have to think about whether we're going to use it off-label, blah, blah, blah. But these are nice problems to have, I would like to put to you. There are things that we can do and have those discussions. Okay. People do contact me about their relative who has, early type 1 or whatever. Should they take verapamil? I mean, we can have that conversation later.
Okay. Last question, short answer and short question, please, because we are running late.
Fernando Gómez Peralta, Segovia. Thank you very much. Amazing talk. 2 short questions. What about combination therapy, and particularly what about the GLP-1 agonist in this immunomodulation? And the second one, probably 90% of this audience are treating adults, and almost all the evidence was obtained in young people. How can we translate all this science into our practice in people starting type 1 diabetes after the 60% starting after 30 years old, or in the so-called LADA diabetes?
Yeah. To answer your question shortly, the second part first, when you start treating a disease, usually treat the highest risk population. So you treat the most aggressive cancers, or the people that you can treat. And children are the highest risk population. They progress much more rapidly. But there's definitely the lower risk population who are the adults, and they definitely need help, and there's lots of them. I think we don't know so much about them. Teplizumab is licensed from age 8 to any age. And they've done that deliberately. So when it comes and somebody is 54 years old, you can't turn them down just because they're 54. Whether the regulatory authorities will say, we'll just do 8 to 18 because we can't afford it, whatever. So it will come and it will spread out from the kids at the beginning. Your other question was about combination therapy. I thought you've done that particularly for me because we'll be starting in 2 or 3 months' time in Europe a combination therapy where everyone gets verapamil and then they get either golimumab or ATG or teplizumab as a combination. I'm okay with that combination. I begin to worry if you put 2 immune drugs together because we can't stand immunosuppressive risk, right? In our disease, we don't want opportunistic infection. If somebody develops an opportunistic infection, you'll all say, I'm never doing this ever again, right? So we need to be very careful about safety. But I think combinations is correct and also sequential. So if you see people failing, like they do in rheumatoid arthritis, you would switch to something else.
Okay. Thank you very much, Professor Dayan. Thank you, everybody, for being here, and we close the session. Thank you.
Muchas gracias.